Hello everyone, my name is Pune Nabavizade and it's my pleasure to be presenting a case of fractured sternotomy wire in the interventricular septum, a rare case of a wire that is going nowhere. I would like to thank Drs. Attari and O'Donnell, who both are senior authors on this case. The presentation of chest pain in patients with prior sternotomy is not uncommon. Sternal wire fracture and migration is a rare cause of this presentation. Chest pain is mostly attributed to irritation of peristernotomy local tissue or of the pericardium by the fragmented wire. Here, we present a case with a history of prior sternotomy found to have a fractured sternotomy wire in the interventricular septum. 63-year-old female with past medical history of hypertension, prior sternotomy for left atrial myxoma resection and a removed TEVAR for type B aortic dissection, presented with chest pain described as a poker trying to get from the inside out. The pain developed after she lifted her brother, was intermittent, sharp, non-exertional, and associated with movement and shortness of breath. Physical exam was significant for mild chest wall tenderness. Her EKG demonstrated no STT abnormalities suggestive of ischemia. Her chest pain persisted despite treatment with NSAIDs, gabapentin, and tramadol. Further imaging workup revealed a fractured sternotomy wire in the interventricular septum. Figure A is a chest X-ray PA view. The gray triangles show the fractured sternal wires and the red arrow points to the migrated wire fragment. Figure B is her chest CTA in axial plane. The arrow points to the migrated wire fragment. The prior TEVAR stent is marked by the asterisk. Figure C is a virtual reconstruction of chest CTA in sagittal oblique plane, revealing sternal non-union. Here again, gray triangles are fractured sternal wires, and the arrow points to the migrated wires, and the TEVAR stent is marked by asterisks. Figure D is a virtual reconstruction of the chest CTA axial plane, revealing the wire fragment location in the interventricular septum, extending to the RV apex. Figure E and F are both chest CTs in sagittal oblique plane. E is a CTA from 2013 and F is a non-cons CT from 2017, indicating the stable location of the migrated wire over 5 years. In Figure F, a leadless pacemaker is present, which is marked by brackets, which was implanted in the RV for symptomatic sinus pauses. In this case, stability of wire fragment position and the lack of further clinical sequelae supported a conservative approach. To our knowledge, this is the first report of a wire migration deep into the myocardium of the interventricular septum. A striking feature of this case is the distance traveled by the wire, more characteristic of a cardiac missile than a fractured sternal wire. Also, considering the distance traveled by the fractured wire, it did not result in any major complications. There are two factors that may have been important in avoiding major complications: the path of the wire entry into the septum and presence of pericardial adhesions secondary to prior sternotomy. This case describes a rare cause of a common presentation: chest pain and palpitations. Migration of fractured sternotomy wires should be suspected in patients who develop chest pain or palpitations following sternotomy. Patient history may provide clues as to the mechanism. Imaging by gated chest CT provides 3D data that can identify sternal wire fracture and localize fragmented wires. Clinical presentation as well as fragmented wire location will dictate a surgical versus conservative approach. Thank you for your attention.